Again, for those listening, thank you so much for watching. This is presented by the Iowa Medical Society on Rural Health in Focus, talking about the HR1 bill and the Rural Health Transformation Fund and its impact. And so looking forward to having an in-depth discussion about how we can address this, what advocacy looks like for our state, and answer lots of burning questions that folks have. My name is Christina Sire. I'm the Member Education and Grant Initiative Specialist for this medical society. Only the speaker and slides will be viewable for the didactic presentation of this, which will take place for about 45 to 50 minutes. So if you're able to turn your camera on, please do so, and feel free to raise your virtual hand or drop something in the chat if you have questions throughout the presentation. This is just to briefly showcase that there is continuing medical education credits for this webinar, and you will receive that within 6 weeks of today. Additionally, for those of us in the room, if you can go ahead and drop your name in the chat and the organization you work for, it just helps us know who's in the room with us and hopefully tailor some of the questions and answers that we talk about. Additionally, our speakers do not have any conflict of interest to disclose. And then lastly, I have the pleasure of introducing our speakers today. And thank you again so much for joining us. Starting with Annalia Michelman, is a senior attorney for the AMA Advocacy Resource Center, the state legislative advocacy arm of the AMA. Annalia has over a decade of experience working in healthcare law and policy as a member of the AMA advocacy team, and she works directly with national, state, and specialty medical societies across the country to craft state laws and policies that enhance the practice of medicine and improve patient care. Prior to joining the AMA, she conducted research on federal Medicaid policy and behavioral health programs and worked on state, legislative, congressional, and other campaigns as political campaign fundraiser. She received her law degree and master's in public policy from Georgetown University and an undergraduate degree in political science from James Madison University. And then we also have Emily Carroll joining us, also a senior attorney for the AMA. And provides legislative policy and legal support to state and national medical specialty societies as well on managed care practices and commercial health insurance reforms. She leads advocacy efforts on key issues, including utilization management, network adequacy, marketplace plans, health plan use of AI, and other commercial payer practices. Emily worked as a legislative director for the law firm Powers, Piles, Souter, and Verbal, PC, in Washington, D.C. She received her law degree from Chicago Kent College of Law, a master's of social work degree. I'm also a social worker, so fantastic to have representation here, and a certificate in healthcare administration and policy from the University of Chicago, and her undergraduate degree from the University of Michigan. That was a very long intro, so thank you so much for hanging in there with me. I'm going to go ahead and hand it back over to our speakers, and thank you all for being here.
Thank you. We are thrilled to be here. Let me share my screen real quick. Okay, you all can see that? All right, excellent. All right, so we have a lot of information to share with you. This might be a little dense, and for that, I apologize. But I'm going to start by talking about the Rural Health Transformation Program, and then talk about some of the big Medicaid changes in HR1. And then I'm going to turn it over to Emily to talk about how these changes, or talk about the ACA changes as well. So, all right, the Rural Health Transformation Program. Congress allocated $50 billion to this new program to be distributed over 5 years. And 50% of the money will be divided equally among states with approved applications, emphasis on approved applications. So that's $100 million per state per year. And this is called the baseline funding. And then the other 50% will be distributed by CMS based off of a state's application score and other factors that CMS might consider. CMS calls the second half of this money the workload funding. And just to start off, there's a lot of interest in this money, understandably, and not to at all discount how big of a number $50 billion is. But I do want to point out that this money will not come close to making up the cuts that states are facing because of the provisions in HR1. The Kaiser Family Foundation which you're probably familiar with, did an analysis and estimates that these rural transformation funds will make up about a third of the funding lost in rural areas. And what's more, in total, the fund is about 5% of the total Medicaid cuts that states are going to face. Keep in mind also that the rural health transformation funding is available for 5 years, whereas the cuts are not time limited. Now, before I get into the details of the program, I want to let you know that the AMA has put a summary of this program and the notice of funding opportunity up on the AMA's website. I'll share the link to that. It's also on one of the later slides. Okay, so how do states access this money? Well, they have to apply. That's very important. They have to apply for both the baseline 50% and the workload 50%. And only states can apply, not any other type of entity, not facilities, not physician practices, not medical associations, only states. So the application has to include a detailed transformation plan, information on the measures and the impact, stakeholder engagement, as well as budget and timelines and that sort of thing. But states only have to apply once. And if they're approved, they'll get funding for the entire 5 years. So the application period opened last week on Monday, September 15th, and it will close on November 5th. So that's a very short amount of time for states to put this together and submit it. CMS has to approve or deny the applications by the end of this year on December 31st, 2025. There was initially a question about whether states would be sort of locked in to what they put in their applications this fall, or whether they'd be able to change the plan over the course of 5 years. And CMS has said that although they recognize that some of the implementation details might change, the underlying strategy, themes, timing, that sort of thing, the big chunks shouldn't change significantly. So what will the money be used for? The application needs to detail, obviously, how states are going to use the money to improve rural health. The statute requires states to use the money on at least 3 of 10 activities, things like prevention of chronic disease, adopting new technology, strengthening the clinical workforce, establishing value-based payment arrangements, and so forth. CMS identified its own 5 strategic goals: make rural America healthy again, sustainable access, workforce development, innovative care, and tech innovation. But what does this really mean? So CMS published the Notice of Funding Opportunity on the 15th, and it described the factors that it'll consider when reviewing these applications. CMS is going to score the applications and then use that score in a formula to determine allocation of the workload funding. So that's that second half of the $50 billion. And for the application score, 50% of that will come from data on the rural characteristics, basically, of the state. So the size of the rural population, the proportion of facilities that are rural facilities in the state, and that sort of thing. So you can see those factors now in that smaller table on your screen. And then the other 50% of the score will come from technical factors. And these are 3 things. There's initiative-based factors, and this is really where states can offer, a lot. This is what they plan to do with the money, the programs, the initiatives, that sort of thing. There's another factor called the state policy-based factors. And these are either current state policy or policies that the state commits to changing or enacting over the next 5 years. And then there's also some additional data-driven factors. So the weight for each factor is provided there in the table on your screen. And as you can see, the technical factors are each make up a pretty small portion themselves for the application. So it's between 1.75% to 3.75% of the total score. And not all of the factors have to be addressed. The weight is for scoring purposes, and funds don't have to be allocated according to these weights. I know that this is all pretty technical. As I said, there's a summary available on the AMA's website that includes all of this. Now, being in the AMA's state legislative advocacy unit, the thing that got my attention was these state policy-based factors. There's 8 of those, and as I just said, the score will depend on whether the state already has a policy that reflects this or whether the state commits to enacting the policy. So these are things like whether the state has or will reestablish the presidential fitness test, or whether they have a waiver that prohibits SNAP benefits for being used on non-nutritious food. Some of these things align well with AMA policy. Those that encourage coverage for remote care, for example. Also, repeal of certificate of need laws. The AMA is supportive of that. But I will say we have pretty significant concerns about some of the policy-based factors, especially the scope of practice factor that is promoting expanded scope of practice laws for PAs, nurse practitioners, pharmacists, and also dental hygienists. Now, having said that, I did look up this. The score is based off of some maps that different organizations have created. So I looked up to see where Iowa was positioned at the start of this. And Iowa will receive the max for 3 of those 4 categories. But I still wanted to point this out because as I said with the last slide, this factor is only going to make up 1.75% of the total score. So it's not individually all that impactful on the application. But having said that, we are concerned that scope of practice expansions are being pushed in this manner. Frankly, that they're being politicized, and the impact that this may have on scope of practice legislation in other states going forward. I also want to touch on the initiative-based factors. Like I said, this is where I think the impact really lies for states, where they can really put some detail about what they plan to do. There's details in the notice of funding opportunity about what CMS is looking for specifically. I have not included that on a slide because, frankly, it's a lot of information and wouldn't really fit on a slide. But it is in the summary that is on our website. So a little bit more about how the funding can and cannot be used. I first want to point out that states are not limited to distributing the funds only to rural facilities, like rural hospitals. Rural hospitals and others should certainly get a share of the money. That was, the initial purpose when Congress created this fund was to compensate the rural hospitals. But the money does not only have to go to rural hospitals. The funds cannot be used to pay for clinical services that are already being reimbursed by Medicaid or any other payer. And they cannot be used to change the payment amounts of existing fee schedules. So this can't be used to directly make up for the loss of federal funding for Medicaid. Relatedly, funding for providers can't exceed 15% of the total funding award in a budget period. Also want to point out that states can't bank the money. They have to spend the money by the end of the fiscal year following the fiscal year in which the amounts were allotted. So to make that a little less confusing, if the money is allotted in, say, FY 2026, the money has to be spent by the end of FY 2027. And these are federal fiscal years that we're talking about. States also have to participate in ongoing monitoring and submit an annual report to CMS on how they're using the funds, and CMS may recoup the funds it determines have been misused. So as for the awards, CMS will base their funding decisions on its review of the state applications and data. They can consider other factors, and they say that they may choose not to fund applicants, with management or financial problems. Statutorily, that second half of the money, the workload funding, has to be distributed to at least a quarter of the states with approved applications. So that does mean that not all states with an approved application are guaranteed to get a chunk of that second half of the money. It doesn't mean that they won't. They certainly may distribute it to all states, but they are not required to. And CMS will announce its funding awards by the end of this year by December 31st, 2025. The legislation also bars administrative or judicial review of the funding decisions, so there's not going to be a way for a state to challenge the award that it received. So those are the details of the Rural Health Transformation Program. As I said, I think there's a lot of focus on the program right now, and I think that that's important, especially in states that have a lot of rural areas. It is not, however, a program that is going to completely compensate for the budget cuts that will be hitting rural areas over the next several years because of what is in HR1. And that brings me to the Medicaid provisions. So I'm going to start with the big picture. And I'm sure that it is news to nobody that states are facing some really big funding cuts in the coming years. And that's true for all states. I don't know if the Iowa state government has put out its own estimates of either the amount of funding it expects to lose or how many more uninsured individuals it expects to see. So I wanted to put out these numbers that are provided by the Kaiser Family Foundation. They did an analysis for each state, and so here you can see how Iowa compares to other states. And the cuts are going to range between an estimated 4% to 20% from baseline federal funding. Iowa is estimated to see about a 17% cut in its federal Medicaid funding. And this is over the course of 10 years, but still, 17% is a pretty big chunk of money. And that amounts to an estimated about $9.5 billion. I was also estimated to see about a 2% increase in the number of uninsured patients, which is around 80,000 people between now and 2034. Most of that is attributable to changes in Medicaid, but not all of it. I'm going to go over some of the provisions that are leading to those numbers. Again, we have some summaries on the website for more information. And the first thing I want to cover is the community engagement requirements, or work requirements, as I'm going to call them. I'll also note that, as I'm sure all of you know far better than I do, the Iowa legislature passed work requirements for Medicaid before Congress passed HR1. There is some alignment, but not complete alignment. And I understand that Iowa's proposal is a little bit stricter in some ways than the federal requirements. And I believe negotiations are ongoing about that. So at any rate, the federal requirements. Generally speaking, states only have to implement the work requirements for the Medicaid expansion population. And this is a theme that we see throughout the One Big Beautiful Bill. The impact for expansion states is bigger than for non-expansion states. So states are mandated to require community engagement for beneficiaries who are not elderly, not pregnant, and not enrolled in Medicare or any other mandatory Medicaid eligibility group. And the requirement is that these folks engage in at least 80 hours of work, community service, or a work program per month, or that they're enrolled in an educational program at least half time, which means 40 hours, or that they have a monthly income of no less than $580, which is the monthly income equivalent of receiving minimum wage for 80 hours of work. Now, there are several exceptions, folks who won't have to comply with these community engagement requirements. I have not listed them all out here, so this is not an exhaustive list, but they include individuals like those who are enrolled in or entitled to Medicaid postpartum coverage, people in substance use treatment, caregivers of dependent children under the age of 14, caregivers of other disabled individuals. Again, this is not a complete list. States also have the option to offer an exemption for short-term hardship, but they are not required to do so. Still, there's really a lot of details for states to work out as they gear up for these work requirements. They can make the requirements stricter than the federal rules require. The HR1 requires compliance for at least 1 month out of every period in between redeterminations. So starting in 2027, that's going to be every 6 months. So an individual is going to have to prove that they're in compliance with the work requirements for 1 out of 6 months. States can require more frequent checks, and they can require that enrollees meet those requirements for more than just that 1 month. I believe the proposal that Iowa submitted is stricter than what the federal rules require. Still, even if states aren't going to make any changes beyond what's in the federal bill, there are a lot of other details for them to work out, like exactly how they are going to determine compliance, especially on things like tracking volunteer hours or gig work. States are supposed to use existing available data, such as payroll data or unemployment insurance data, to determine whether an individual is complying without, where possible, requiring the individual to submit additional information. So states are going to need to figure out what additional data sources are available, how they're going to use that data, and importantly, what IT upgrades they might need to make happen in order to link the various data sources that they might have. So just as some examples, there's Medicaid claims data through all the payers. They could potentially use that claims data to identify people who would be exempt. Exempt because they have a serious or complex medical condition, exempt because they have a substance use disorder or something like that. It might also be possible to use tax return data to determine if somebody has a dependent and therefore might be exempt. But states are going to have to figure out exactly how they're going to do that. There may be opportunities to define exceptions, although CMS has to issue rulemaking by June of next year. So we don't yet know to what extent states will be able to define the exceptions, but assuming that they will have some leeway to determine what it means to be exempt, states will need to think through some of that. So, if somebody has a serious mental illness, what exactly does that mean for purposes of an exemption? What serious and complex medical conditions make for an automatic exemption? They will also need to come up with a lot of processes, how they will deal with appealing a decision. They'll need a process for notice of noncompliance and disenrollment, as well as outreach to make sure that beneficiaries know that there are these new requirements. And as I said, CMS is required to issue rules on this by June of next year. So the legislation, HR1, included $200 million for state grants to implement the community engagement requirements. 100 million of that will be allocated evenly between the 50 states. So that's $2 million per state. And the remaining 100 million will be divided among the states based off of the size of their Medicaid population. So it's not a lot of money that's being provided for implementation, but it's also not nothing. So here's a quick timeline about the community engagement requirements. States can implement at any time before they're required to. CMS has to issue rules by June of next year, and then beginning in January of 2027, that's when states have to verify Medicaid patients' compliance with the program requirements. So that's a very short timeline. CMS could put out the rules more quickly, but their deadline is June of next year. So if they don't get the rules out before then, states will have between June of next year and January of the following year to implement this. That's only 6 months' time, which is quite quick. States can get an exemption for up to 2 years. CMS can give a good faith waiver. it can only be the waiver is only permissible until January of 2029, so 2 extra years. And CMS can terminate the exemption if they find that a state isn't acting in good faith. So before I turn to the next provision, I want to talk for just a second about the implications of all of this. So work requirements make up the biggest share of federal Medicaid savings in HR1 because people are going to lose coverage. That's where the savings comes from. The vast majority of Medicaid patients who can work already do. So there's not all that much room for increasing labor participation from the Medicaid population. So unfortunately, what we expect to see is procedural disenrollments, people who are in fact eligible for Medicaid, but for whatever reason, they haven't documented that, haven't met the paperwork requirements, basically. And in the few states that have implemented work requirements before, that's what we've seen. Arkansas had a brief work requirements experiment where they cut 19,000 people from their Medicaid rolls in less than a year. Most of those people were in fact eligible, but they didn't know how to comply or couldn't comply with the paperwork. This will also lead to a lot of churning off and on the program, people becoming disenrolled and then re-enrolling. That, of course, as you all know, leads for a lot of administrative burden for you all, for physician practices, for the patients. It leads to disruptions in care. It also is going to be very expensive for state governments. The administrative cost of implementing this is going to be quite large. In Georgia, just as an example, they have a work requirements program that has cost the state somewhere around $86 million. That includes $55 million for a new eligibility verification system. As of earlier this year, the first part of this year, only about 7,000 people were actively engaged in that program. So a pretty tremendous administrative cost. I also want to point the last thing about community engagement requirements is that if a Medicaid beneficiary loses Medicaid coverage because they fail to comply with the work requirements, that makes them ineligible for marketplace subsidies. So they won't have Medicaid, they won't be able to afford marketplace coverage. They probably won't have access to employer-based coverage because few low-income jobs do. And therefore, they will likely be uninsured. So another big provision in HR1 with a big budget impact is related to provider taxes. CBO estimates that these changes are going to cut $191 billion in federal spending over 10 years. Now, the ins and outs of provider taxes can be a bit complex. The mechanism here is something called the hold harmless provision. We could do an entire separate discussion on how provider taxes work. So just for our purposes today, suffice it to say that this is going to make it very, very difficult, if not impossible, for states to enact any new provider taxes. And that's why you've seen probably any discussion about this provision in the bill. It says that states are prohibited from enacting any new provider taxes. That's not strictly true, but in effect it is. So in non-expansion states, they'll be able to continue their existing provider tax arrangements, but cannot alter them. In expansion states, they're going to have to lower their tax rates. So this is another instance of expansion states being treated differently from non-expansion states. So the hold harmless threshold here in expansion states is going to be lowered. And beginning in the year 2028, the tax rate on net patient revenue has to be lowered by 0.5% each year until it reaches 3.5% in 2032. This reduction does not apply to provider taxes on nursing facilities or intermediate care facilities. The previous 6% threshold still remains for those. And states that have a waiver may have up to 3 years to adjust their waiver. I don't believe Iowa is one of the states with a waiver, though. The impact here, of course, is financial. This is going to create significant budgetary challenges for states, including likely in Iowa. I believe Iowa has several provider taxes like most states do, although I do not know what the tax rates for those are. And as a result of these budget challenges, states are going to have to either find new revenue, which I'm sure states will find some new revenue, but they're not going to be able to completely fill this budget hole. It's just too big. So they're going to have to make cuts somewhere. Congress didn't directly cut eligibility or benefits, but states might have to. They may also have to do things like cut Medicaid reimbursement rates. This is going to be pretty limiting, this big budget hole, in terms of how states can respond to emergencies. In times of economic downturn, there's more demand on Medicaid, or if there's, say, a natural disaster, there's more demand on Medicaid. And typically states have had, different ways of raising more money to pay for that. And so restricting provider taxes for states is going to be quite limiting. I'll also say that provider taxes had been used increasingly as a way to increase physician reimbursement rates. Well, not just physicians, all reimbursement rates for all types of different providers. That strategy is now off the table. So we're going to need to think of other ways unrelated to reimbursement rates to keep physicians and others participating in the program. That doesn't necessarily hinge on reimbursement. Two other provisions that I want to touch on kind of quickly. The first is the biannual eligibility redeterminations. Beginning in January of 2027, so the same time that the work requirements kick in, states will have to conduct redeterminations every 6 months. Previously, it was 12 months at a minimum, or at a maximum, sorry. States couldn't conduct redeterminations more often than every 12 months. Now they have to do it at least every 6 months. CMS has also said that they will no longer approve any state requests to provide more generous continuous eligibility. So in terms of implications here, we learned from Medicaid unwinding after the pandemic just how challenging these redeterminations can be and the risk of procedural disenrollment. So that is, again, the beneficiaries who are in fact eligible, but for any number of reasons have not provided the documentation to maintain coverage. We know from the unwinding that this leads to coverage losses, obviously, also leads to churn on and off the program. That in turn leads to disruptions in care, interruptions for your practices, and some, administrative hassle. And then the last thing is state-directed payments. You've probably heard a lot about this. This may not be the most relevant for all physician practices, but it has a pretty big overall impact on the Medicaid budget, saving the federal government $149 billion. So I wanted to mention it. State-directed payments are when the state Medicaid agency instructs the Medicaid managed care organization that makes the payments to pay certain providers in certain ways. So in the reconciliation bill, state-directed payments are capped for inpatient hospital services, outpatient hospital services, nursing facility services, and qualified practitioner services at academic medical centers. And it is only those services for which state-directed payments are capped. That's because previously, the cap had been raised to the average commercial rate for only those services, and now they're bringing it back down. This is another instance where the rule depends on the state's expansion status. So in non-expansion states, the cap is going to be 110% of Medicare. In expansion states, the cap is 100% of Medicare. There's a grandfathering provision. So starting in 2028, states will have to decrease their state-directed payments by 10% each year until they hit the allowable amount. And this timeline aligns with the timeline for provider taxes. So this is when states are going to really feel the budget hit of all of this. And I'll also say that CMS recently put out guidance for these state-directed payments where it said that it's looking at capping all state-directed payments at Medicare rates, but it has not yet done so. So those were just a few of the Medicaid provisions in HR1, the ones with the biggest budgetary impact, but certainly not all. Up on your screen, you can see some of the other Medicaid provisions. There's a lot here. We could spend a lot of time covering this. I just wanted to hit on some of the big ones. And as I've said before, we have some summaries. If you are interested in more information, that's available on our website. And with that, I'm going to turn it over to Emily, who will talk about some of the ACA marketplace provisions.
Great. Thanks, Annalia. And thank you so much, everyone, for inviting us to be with you today. I am going to take a few minutes and just talk about some of the major changes to ACA marketplace plans that were a result of both, and Annalia, I might have you go to the next slide, sorry, that were both the result of HR1, or the One Big Beautiful Bill Act, as well as a market integrity rule issued by CMS in June of 2025. And those two major pieces of work by the administration and Congress have really resulted or will really result in significant changes to affordability, eligibility, and enrollment in marketplace plans. I'll just note that in July, a group of cities and organizations filed a lawsuit against the administration seeking a stay of some of the provisions in the market integrity rule. And there is, in August, the District Court for the District of Maryland ruled or issued a nationwide stay on some of those provisions. So as you'll see in the next couple of slides, I've put an asterisk next to the provisions of the rule that are currently stayed, meaning their implementation is suspended. So Annalia, next slide, thanks, sorry. So first, if we're talking about affordability, the fact that the One Big Beautiful Bill, or HR1, did not extend the enhanced premium tax credits is really devastating to affordability. These tax credits were enacted in 2021, as part of the American Rescue Act, and have significantly improved affordability of marketplace plans. They increased tax premiums for people with incomes below 400% of the poverty level. They also allowed those above 400% of the poverty level to apply for some credits, and they kept premiums at they kept premiums at 8.5% of people's income. So really made a significant impact on affordability, which has resulted in a record high of more than 24 million people being enrolled in marketplace plans. And it's also improved the overall risk pool of the marketplace plans, which has further lowered premiums for everyone. So if these tax credits are not extended, we are really likely to see a steep hike in premiums. There's estimates of 75% or more out-of-pocket increases on average for enrollees. For example, a 60-year-old couple with an income of $80,000 would see an increase in their premiums of about $17,500. So really significant to enrollees. We're also likely to see an increase in the number of uninsured. The Congressional Budget Office estimated that about 4.2 million people will become uninsured if these tax credits are allowed to expire. And that's on top of the 10 million plus people who will become insured as a result of HR1. We're likely to see less stability because we'll have a less healthy risk pool. And we're going to see more financial stress on physicians and hospitals as a result of a rise in uncompensated care. So there's still lots of time for Congress to act to extend these tax credits, and the AMA and the Iowa Medical Society, we're all working to advocate for an extension. So hopefully more to come on that. Next slide, please. In addition to the affordability issues, or kind of setting aside the affordability issues associated with the enhanced premium tax credits, there are also a number of provisions in HR1 and in the final marketplace rule that will significantly impact affordability. And it's mostly by sort of erecting new barriers to accessing premium tax credits. Most enrollees use advanced premium tax credits to help lower their premiums, and that requires an estimate of income at the beginning of the plan year. And then at the end of the year, the enrollees have to reconcile those estimates with their actual income and make adjustments to their premium tax credits if they received more tax credit than should have been provided. Under the new law, there is no longer a cap on the amount of money that low-income consumers have to repay if their if the tax credits they received were more than they should have received. So currently there's a cap on some of these repayment requirements. And because of these changes, a lot of enrollees may have to pay past due premiums to obtain coverage and incur unexpected tax liabilities at the end of the year. So it could be really a hardship for low-income enrollees. The new law also extends provisional eligibility for marketplace, or also ends provisional eligibility for marketplace coverage beginning in plan year 2028. So currently, individuals can receive a subsidy for a limited time while their eligibility is being verified. But this change will really impact the ability of enrollees while they're kind of getting that verification done to enroll in marketplace coverage. So we'll likely see a drop there. Next slide, I think. All right, so there's also going to be some major changes to enrollment as a result of the new rule and the new law. Coming next year, we will see significantly shorter enrollment periods, so by a whole month. On the federal exchange, there's a set timeline between November 1st and December 15th for enrollment. And if you're a state-based market, exchange marketplace, you have a little bit more flexibility, but still only can be 9 weeks. So significant reduction in the time that folks have to sign up. Additionally, the final rule, in combination with some changes in HR1, essentially ends the continuous special enrollment period for low-income individuals who are not eligible for Medicaid. So currently, low-income individuals can sign up for marketplace coverage at any time. And this has been in place for a couple of years now, but the new reconciliation bill ends that opportunity, the reconciliation bill and the final rule. And then I think maybe most importantly, in terms of enrollment, the HR1 ends automatic re-enrollment and requires everyone to actively re-enroll in marketplace plans, even if all their information and eligibility information stays the same. And this is a really massive change. This year, almost 11 million people out of the 24 million people enrolled in marketplace plans were automatically re-enrolled. So that's about 45% of enrollees. So there'll be really a need for significant education and outreach to enrollees to let them know about this change and encourage them to actively re-enroll. But we're likely to see a huge drop because of that change. Next slide. And then eligibility. I think, one of the biggest things done in both the rule and HR1 are restrictions on immigrants' access to marketplace plans. So the final rule prevents DACA recipients from enrolling in marketplace plans. So DACA recipients are no longer eligible to purchase health insurance on the marketplaces. So that's a huge impact on both that population as well as on the risk pool for marketplace plans. DACA recipients are generally younger and probably healthier, using less healthcare resources. So really, really devastating to remove that group of people. The HR1 also prevents many groups of lawfully present immigrants, including refugees, asylees, and those with temporary protected status, from receiving tax credits starting in plan year 2027. And then before that provision is implemented, there was a requirement this coming plan year that the same groups of immigrants with incomes below 100% of the poverty level who are waiting the required 5 years to be eligible for Medicaid will not be able to access tax credits on the marketplace, so essentially won't be able to afford marketplace coverage. There's also a number of other eligibility changes in HR1 and in the final rule, including the end of provisional eligibility for marketplace coverage, and that begins in 2020, plan year 2028. So currently, individuals can receive a subsidy for a limited time while their eligibility is being verified and checked. That'll really make it harder for a lot of folks to re-enroll in coverage and will probably result in a large drop in coverage altogether. So next slide, please. So just kind of to summarize, these marketplace changes, which marketplaces, again, allowed 24 million people to have coverage. It's really going to be a challenging time for these marketplaces. We're going to see fewer folks having access to marketplace plans with all the new administrative requirements and the end of our enrollment. And that'll lead to higher premiums and higher costs as healthy people exit the marketplace. So sort of a vicious cycle of access and affordability coming to marketplace plans. So next slide. So this slide is just sort of next steps, which is like, we probably need 30 slides to talk about the next steps here. But there's a lot of opportunity for states, state governments, state regulators, and state advocates to really engage and help mitigate some of the harm that's going to be coming from a lot of these changes, both Medicaid and ACA changes. Certainly a lot of education and outreach to patient and physicians will be needed. I think all of us will be engaging the medical, the House of Medicine, and will be engaging in the rulemaking process. As Annalia mentioned, a lot of Medicaid rules and guidance yet to come. We're also planning to work with our colleagues in the states, with state policymakers, to really, set up the needed processes to meet these new requirements, and finding all the opportunities we can in the states to really help people continue to access coverage. And then I think we have storytelling up there, and I think telling the story is part of our advocacy on the success of coverage and then dangers in patients losing it, and what that means for physician practices and for patients, I think will be a really important part of the process. So the AMA is really committed to being a resource for physicians and the medical societies. This work is going to be really hard, I think, over the next couple of years, but definitely necessary. So we're looking forward to working with the awesome team at the AMA Medical Society on a lot of this, and yeah, we hope to be a resource for you all. So happy to take any questions. There was a link to a website we've stood up on the AMA page where we'll be posting a lot of our resources in the coming weeks and months. And yeah, so happy to answer any questions, I think.
Fantastic. Thank you so much for diving deep into the complexities of this issue. We did have a question in the chat relating to the Rural Health Transformation Fund. Can the funds be used for existing services, or is it only applicable for new services?
So the answer to that depends on whether it is already paid for by another payer, by Medicaid, Medicare, private insurance. So the rural health funds can't be used kind of instead of or even in addition to the existing Medicaid money or existing reimbursement for that service. It can be used for things that are not already covered, though, by another payer. I don't know if that fully answers your question or not.
Yeah, that was my question. I believe it does. So if something is maybe currently being funded by a state agency or even another federal grant, as long as it's not from CMS, it could fund an existing service.
I see. So you don't mean something that Medicaid or health insurance already covers. You mean something
Right.
like a grant.
Right.
Let me look into that for you, because I want to make sure I'm not giving you that information.
Sure, no worries.
Yeah.
I looked in the NOFO and it wasn't entirely clear to me either. So yeah, appreciate it.
Sure.
Any other questions for the speakers?
I see Dr. Kitchell had one that I can speak to briefly. I will say we have been in contact with the Department of Health and Human Services and Medicaid on the Rural Health Transformation Fund. Given the announcement yesterday that the HHS director is departing, there is obviously some leadership changes there. And so we're kind of working through that to see how Iowa's application is going to look. But I will say that we're in the process of meeting with the new Medicaid director as well. So the leadership changes have added some uncertainty, I would say, but we are having those meetings and putting together our proposal on how those funds should be used. This presentation helps a lot, but we have communicated what we think would help the workforce shortage in other areas that Iowa is struggling in. So hopefully that helps.
Beth, would you be able to speak more about what some of the things like workforce shortage, or there other things that IMS would be focusing on for the application?
I mean, there are a lot of factors that they're taking into account that we would love to see improvements on. I know one of the focus was EMS, and that's obviously something that we have talked about before. If there are opportunities for loan repayment or reimbursement, those are all areas that we're trying to point HHS and Medicaid towards. I think it's a question as to how much, that decision is going to be internal versus external. But I'd say so those are some of the areas where we're suggesting, and I think the meeting with the Medicaid director should be illuminating as to how they're thinking about using the funds.
And we do have another question in the chat. How many states have used directed payment for physician fees? Iowa currently pays 50% for Medicaid compared to Medicare.
That's a good question, and one that I cannot answer off the top of my head. I will say that state-directed payments are only relevant in the context of Medicaid managed care, because the whole idea around Medicaid managed care is that, the state kind of outsources payment. So the managed care organization gets to decide how much they're going to pay. That's what networks are for, and, that sort of thing. And with Medicaid managed care being far and away the predominant delivery model for Medicaid, that makes state-directed payments kind of a bigger piece of it, because states still want to maintain a lot of that control over how things are getting implemented. It's also a major way that states have required managed care companies to engage in like value-based payment programs and different kind of payment models. They instruct the managed care company to do certain things. So I don't know the answer to that across the whole country, but I suspect that it is ultimately fairly high, although probably still lower for physicians than it is for, say, hospital services that I think rely a lot on state-directed payments.
Thank you. And Dr. Jenkins is echoing a question that I was going to say at the end as well, is what is the best way for physicians to make sure we are active participants in determining where the Rural Health Transformation Fund money goes?
I think that is why you are engaged with your state medical association. As Seth just talked about, you all are involved in conversations with your state folks. That is your point of influence, because only states can apply for this money. It might also be useful to talk to the state about how they plan to distribute the money. The application is one thing, but then once the state has the money, it has discretion in how it's going to use it. It has to be in line with what the application said, but the state can distribute the money to facilities or to other entities based on its priorities.
Thank you. Does anyone else have any questions? If not, I'll go ahead and end the recording.